With increased pressure from governmental agencies, health insurance companies, medical boards, and healthcare systems to decrease the total daily dose of opioids, you can expect to see an increased pressure to get you on a lower dose of medication. We can expect this pressure to maintain patients on a lower dose will continue into the foreseeable future, and as a patient, you should be aware of this pressure and the impact it may have on you. We live in a pill-embracing culture, a culture that has led to unrealistic expectations as to what these pills can safely do for you. We have recently gone through a phase where giving higher and higher doses of narcotics was considered good medical practice, to the current stance that it is poor medical practice to prescribe opioids. This has led to frustration and confusion, and a considerable potential problem, a condition called opioid use disorder. Opioid use disorder is essentially a narcotic addiction to a prescription dose of opioids. A large number of patients have suffered the same brain neurological changes that occur in the brain of a heroin addict, but in this case it is developed in an attempt to control pain and not to seek a euphoric drug state. They have taken their medications as prescribed and have been compliant with therapy, but the narcotics have changed both the structure and the function of their brain. The prevalence of opioid use disorder among patients receiving even low daily doses of opioids has been reported to be as high as 41%. The medical community has been trying for several years to wean patients to a lower dose of narcotics. This has been a very difficult task with lots of resistance and anguish. With some patients, the reduction of dose has been very successful, and they have tolerated the 10% reduction per month without a problem. For others, it has become a major problem. This is a battle that can leave both you and your healthcare provider both bruised and burned out. The battle exists because the treatment being offered is for the wrong diagnosis. Treating an opioid use disorder as if it is pain will only lead to conflict, turmoil, confusion, and frustration. Have you seen this look on your primary care provider? Frustrated because of pressures to get you on a lower dose of medication, and you are resistant to the change. Frustration that can quickly erode a trusting doctor-patient relationship. Frustration because your provider wants the best for you, but the options are very limited. So how do you know that you might have an opioid use disorder that is now complicating your treatment for chronic pain? Let's look at some of the specific characteristics of the opioid use disorder and how it might be experienced. Make it clear, I am not saying that your pain is not real. Your pain is very real. And if you have opioid use disorder, your pain is most likely out of control and having a huge negative impact on your life. Firstly, will be that you are resistant to any reduction in the opioids you have been on for years. You just don't see the need for a change. Even though you are still in a lot of pain, you don't want any change in dose. You will have experienced that increasing the dose of opioids in the past has given only a minimal and brief improvement in your pain symptoms. If you had it your way, you would still increase the dose. You have found yourself running out of your prescriptions early. This is a sign that the medication has taken too much control of your life. You're experiencing significant life interference. There is no clearly defined reason for why your pain has existed for so long. This is a sign of pleasure being lost in all areas of your life except with opioid use. This is a clear indication that opioid use disorder is present. You are no longer free to experience normal life rewards like conversation, food, or exercise. You will begin to experience increased cravings, such as the need for an extra dose at night or an extra dose in the middle of the night. You may have evidence of other addictions to things such as food, alcohol, gambling, marijuana, nicotine, or microprocessor use. Is more common with conditions like post-traumatic stress disorder, fibromyalgia, or irritable bowel syndrome. So now that you've taken an honest inventory and feel you may have an opioid use disorder, now what do? Firstly, do not give up hope. If this is treated properly, there is very good chance that you will see significant improvements in your life and in your battle with pain. This is a complex and complicated situation. Some understanding will go a long way to make the path a lot smoother. First of all, you'll need to understand the disease you are dealing with. Not the pain diagnosis disease, but the opioid use disorder disease. You'll need to understand the specific issues you may have as a patient, as well as the dilemma of treating a disease that you do not believe you have. The opioids, although not as strong as heroin, have caused the same type of brain structural and functional changes. For more information on this, please view the video on the disease of addiction. This will help you understand what is going on with your nervous system. Unfortunately, your brain is addicted to opioids. You did not choose for this to happen. When you start to wean from the opioids, you begin to experience a physical pain much worse than the pain caused by the disease for which the opioids were originally prescribed. This may be the first sign of an opioid use disorder. Please be patient. There are solutions. You are clearly suffering, and yet the treatments you have been given in the past for the suffering are being removed. Your medical provider was not trying to harm you by prescribing opioids for your pain. It was considered the standard of medical practice in the past, but that standard has changed drastically. If we only knew then what we know now, then the problem would not have grown like it has. Unfortunately, we did not know then what we now know. Your provider does have some good options and will work with you. You will need to make this shift from being a pre-contemplator who does not believe change is necessary to a contemplator who is now open to options. This can be a very difficult shift, and you will need a foundation of trust with your healthcare provider. Then you can gradually move towards contemplation. This will take time. Your healthcare provider has been taught to help you move along this path with the following techniques. First is to teach you just a little at a time. This will require multiple visits, possibly over months. They are encouraged to go slow and to be patient. Again, this will take time. You will be provided options. The option of remaining on high-dose opioids, however, will not be one of your options. But there are many other options you can discuss at an office visit with your healthcare provider. Be willing to follow up on the options and be willing to ask if there are any other options. Some of the options provided may be referral for physical therapy, referral to a pain specialist or addiction specialist, starting on a medicine called buprenorphine, refer for a methadone clinic, or weaning of one drug at a time. This will require frequent office visits. It may even require weekly office visits for a while. You'll probably experience a change in office policies. These changes are considered boundaries to keep you safe. Some of the boundaries you may experience may be the following. You may be asked to be seen more frequently than you are used to. You may be asked to bring your medication with you to the office or be called in for random pill counts. You'll most likely not be allowed to get early refills. You'll not be provided refills for lost or stolen medication. Your provider may have a policy that does not allow for alcohol or marijuana while you're on opioid medications. You will be asked for more frequent drug screenings. You may have to come to the provider's office for refills. Your provider will want to decrease and most likely eliminate medications like benzodiazepines while on opioids. These are medications like lorazepam, Valium, Xanax, or sleeping pills. These measures are for your long-term safety. Please be patient. This is not easy for your healthcare provider either. Please do not take this process personally and do not become hostile towards your provider, the pharmacist, or the healthcare provider's office staff. Please be patient. Having an opioid use disorder is a problem, and can be the cause of a lot of confusion, resistance, and conflict. Resistance is high, but change is necessary. We are not going back to the days of high-dose prescription opioids. Options are necessary. Boundaries are necessary and often life-saving, but not welcomed. You will question, why do I need boundaries now when I didn't when I was on a higher dose in the past? Be patient as you are asked to adhere to the boundaries. Your provider is not concerned about your pain. They are aware of the pain and it has a major impact on your life. But at this time, the treatment for the opioid use disorder must take priority. To focus on this will give you the best chance for a positive, long-term positive result. As the weaning of your medication continues, there are only 4 possible outcomes. The reduction of opioid dose may be successful. You have tolerated the 10% reduction per month without a problem. You are now free to move on with your life. This would not be considered an opioid use disorder. You may be able to decrease the dose to a point that you can no longer tolerate the dysfunction in your life caused by the lower dose of opioids. At this point, the weaning may be slowed down or even paused for a month or so. If this fails, you may be asked to be transitioned over to a medication called buprenorphine. This may require the referral to a doctor who has a special license from the DEA to prescribe the buprenorphine. Our experience at the addiction clinic where I currently work is that approximately 85% of these patients transferred to buprenorphine do extremely well, with significant improvement in their life. At this point, you may be advised to attend classes that can help with this condition. Programs like chronic pain classes, exercise classes, or group meetings with other patients that suffer from the same opioid use disorder may be very helpful. The problem here, however, is that there are very few of these programs at the present time. A small percentage of patients transition to buprenorphine do not do well on the buprenorphine. Treatment at this time may require a referral to a methadone maintenance program or consultation with a pain management specialist. I hope this helps you understand why your prescription opioids are being reduced and what the process might look like. Please be patient. It will be worth it in the long run. For additional references and help, please refer to the Fractured Resilience website. Thank you.